Today's presentation is about nephron sparing surgery. I will try to cover the brief history of renal masses and nephrectomies, followed by an introduction and terminology and pathology, staging and classification system, diagnostic evaluation, little bit about, then a detailed disease management for clinically treatable disease, followed by application of nephron sparing surgery and partial nephrectomies, surgical approaches and techniques, and preventive measures during NSS and partial nephrectomies, a case presentation, and in end we will talk about recurrence and follow-up. We try to complete this all in this presentation, otherwise if we left behind, I will go for the next question. So in the history of nephrectomy, Carl Johann Langerhans in 1875, he was a British surgeon who did the first nephrectomy for a patient of renal tumor. Sir Thomas Spencer Well in 1884, he did the first partial nephrectomy, which was accidentally performed by removal of perirenal fibroadenoma. Then Gustav Simon in 1869, he did first successful nephrectomy, a case of a ureterovaginal fistula. While hesitation for the procedure of NSS, because it's not commonly performed, complications include wound infection leading to what was called hospital gangrene, and the mortality was high, even leading up to 40% in NSS. So, what is in a name? Why the renal cell carcinoma is called as renal cell carcinoma? Hypernephroma controversy, 1883, which me and Dr. Imran was discussing in Operation Theatre. Previously, this renal cell carcinoma was known as hypernephroma. All gravis, although this tumor was known by its name, gravis tumor, arises from small ectopic adrenal abscess. The first illustration from rare PFO treatise of disease of kidney in 1841. So going back in time, we met many pioneers and their ideas. When did we do partial nephrectomy? So the short answer for the question is radical nephrectomy by many and partial nephrectomy by a few. So this is all about brief history and of renal masses and NSS. So we come to the epidemiology, etiology and pathology. Renal cell carcinoma, 3% of all cancers according to EUA 23, with higher incidence occurring in Western countries. Annual increase of about 2% in incidence both worldwide and in Europe, leading to approximately 92,000 new renal cell carcinoma cases and 31,000 kidney cancer related deaths within the European Union in 2018. Lifestyle such as smoking, obesity and hypertension, these all are the etiological factors, although risk factors as well for renal cell carcinoma. In recent SR also diabetes mellitus was found to be determinantal. First degree relative with kidney cancer is also associated with an increased risk of renal cell carcinoma. Well, surprisingly moderate 40 ml approximately consumption of alcohol intake appears to have a protective effect for reasons as yet unknown. Most effective prophylaxis is to avoid cigarette smoking and reduce obesity. So, recommendation which carries strong is increase physical activity, eliminate smoking, and in obese patient reduce weight as the primary preventive measures to reduce risk for RCC. In pathology, there are three distinguished types of renal cell carcinoma. Number one, the most common and carries worst prognosis is clear cell carcinoma, renal cell carcinoma, in which loss and mutation of chromosome 3p25 of VHL, one nickel window gene, and its most common 5-year cancer specific survival rate was 91%, for TNM stage 1, then 74% for 2, 67 and 32 for stage 3 and 4 patients. It's data from 1987 to 1998. Second most common is papillary renal cell carcinoma, which carries two types, type 1 and type 2, mutation in MET gene, relatively good prognosis. Third one is chromophobe renal cell carcinoma, in which loss of Y chromosome also carries good prognosis but is less common. This is the TNM staging and classification system. We will stick to G1, that is tumor less than 7 centimeter or less in greatest dimension, and is limited to kidney. G1A, tumor which is less than 4 centimeter, less than or equal to 4 centimeter. G1B is tumor greater than 4 centimeter but is less than 7 centimeter. So nephron sparing surgery is indicated in G1 disease, clinically G1 disease. Otherwise, this is the old GNM for renal cell carcinomas. Anatomic classification system is very important impact while doing nephron sparing surgery. There are different scoring systems. Padua Renal, which is a worldwide used scoring system, nephrometry score, C-index score, AVC scoring system, and zonal nephro scoring system. All these carries weak recommendation in 2023. Well, worldwide use is renal scoring system. As it name indicates, R is for radius. This basically scoring system was provided by a radiologist. R carries radius, which maximum diameter in centimeter. For patient 1, patient points 2 and point 3. There are 3 types of points. So radius is less than 4 or equal to 4 centimeter in point 1. Then in point 2 points is 4 greater than 4 centimeter but less than 7. And in 3 is greater than 7 centimeter. E is for exophytic or endophytic, 50% greater than 50% or less than 50% entirely endophytic in 3 points. N is for nearness of tumor to the collecting system or sinus. This is the measurement of the nearness. Then again it's anterior or posterior. No point given for anterior or posterior. Mass assigned as A, P or anterior or posterior, or this X is for intrapolar, like it lies in the mid-pole, in between the anterior and the posterior, upper or mid-pole. And L is for location relative to the polar lines. So this is the polar line, upper, in between the upper and mid-pole, then mid and lower pole. These are the polar lines. In between of these, a center dotted line is the demarcation in where the collecting systems, minor calyces, major calyces, then pelvis. So these are the score for the patient who underwent going for nephron sparing surgery. So location relative to the polar lines entirely above the upper or below the lower polar line. So lesion crosses the polar line in 2 points, but in 3 points, if you see A is the mass is across the polar line. This one is the A. Here is the polar line, so it's crossing the polar line, or a mass crosses the axial renal midline. This one is the midline crossing by the mass. So H is for suffix assigned for tumor touches the main renal artery or vein. So it's a very difficult classification which was mainly aided by radiologists. So with the help of radiologists finding according to the CT angiography, CT venography, CT arteriography, we decide patient is fit for nephron sparing, either nephron sparing surgery or radical nephrectomy. So in the diagnostic evaluation, this slide is mainly for general surgery trainees. We look into the detailed history of the patient. Symptomology: 50% renal cell carcinomas are incidental. Mostly they were called as incidentalomas just because they are incidentally found when patients go for some other pathology, abdominal pain, they turn out to be a renal tumor. A classic triad of flank pain, hematuria that was visible, and palpable abdominal was is 6 to 10%. If a patient carries this classical triad, then more than 50% of the tumors are metastatic at initial presentation. So paraneoplastic syndrome, approximately 30% of the patient with symptomatic RCCs. We need to ask about the metastatic symptoms. Then physical examination, obviously an abdominal mass, cervical lymphadenopathy, non-reducible varicocele. Fred is going to answer this question, why there is a non-reducible varicocele and lower limb edema. So, paraneoplastic syndrome, although it's not in this carries in this nephron sparing surgery, but we need to know about little bit about paraneoplastic syndrome. It's a disease or a symptom that is a consequence of cancer cells. It's mediated through cross-reacting antibodies, production of physiologically active factors, interference with normal metabolic pathway. It's idiopathic as well. So there is endocrine manifestation and non-endocrine manifestation of paraneoplastic syndrome. In endocrine, there is hypercalcemia, hypertension, polycythemia, non-metastatic hepatic dysfunction, which is also known as Stauffer syndrome, galacturia, alteration in glucose metabolism. In non-endocrine, amyloidosis, anemia, neuromyopathies, vasculopathies, nephropathies, coagulopathy, and prostaglandin elevation. Stauffer syndrome is a rare paraneoplastic syndrome classically reported with renal cell carcinoma, syndrome of unclear pathophysiology. It's characterized by reversible elevation of liver enzymes, alkaline phosphatase, ESR, thrombocytosis, prolongation of prothrombin time, and hepatosplenomegaly. Absence of direct hepatobiliary obstruction or jaundice. So a rare atypical variant of this syndrome with jaundice and pruritus has been described in the literature. Liver biopsy will reveal cholestasis and occasional non-specific infiltration of neutrophils, lymphocytes, monocytes, and rarely granulomas. So after history and examination, there comes to laboratory tests, investigations, in which complete blood count, renal function test, estimated GFR, LFTs, alkaline phosphatase, LDH, and serum corrected calcium. Ultrasound, very initial basic investigation to be performed is ultrasound kidney urine bladder, which represents a renal mass, followed by a contrast enhanced kidney urine bladder, which shows for renal masses. CT arteriogram and venography in case of NSS to differentiate either tumor according to the renal scoring system. So arteriography and venography is important in the case of NSS. Contrast enhanced ultrasound carries very important role when comes to renal vein thrombus, IVC thrombus, to differentiate from the other pathologies. MRI with contrast, same as CT, only difference priority when it comes to venous involvement like renal vein thrombus, IVC thrombus, and complex renal cyst like 2F and 3 according to the Boston classification. HRCT test for metastatic workup. TMSA is rarely performed in renal masses, especially in case of solitary kidney when we need to preserve the kidney. PET scan is not routinely performed in renal cell carcinomas. Biopsy can be offered for fragile patients on which we can give chemotherapy or no metastatic. Usually we have to get the biopsy. Or in very early patients, I have a patient nowadays in my OPD. He is a 28-year-old with renal mass and highly suspicious for lymphoma. So for those patients, we can go for biopsy because lymphoma can respond to chemotherapy. So these are the latest recommendation for 2023, which carries strong for CT. MRI is image to better evaluate venous involvement, reduce radiation, and avoid intravenous contrast medium. Then do not routinely use bone scan or PET scan CT for staging renal cell carcinoma. Perform renal tumor biopsy before ablative therapies. We discuss later on ablative therapy and systemic therapy without previous pathology. Then perform a percutaneous biopsy in selected patients who are considering for active surveillance. It carries weak recommendation. So these are the biopsy techniques. Coaxial techniques is used. Do not perform renal tumor biopsy for cystic renal masses. Very important for posting. We need to go if is type 1, type 2 or 2F. 2F to follow, 1, 2 is no need to follow. 3, 4 is definitive surgery because they carry high potential for renal cell carcinoma. Use a core biopsy technique rather than fine needle aspiration for histological characterization for solid renal tumors. Very strong rating. So the main topic is treatment of clinically T1 disease. Gold standard is nephron sparing partial nephrectomy. In ablative techniques, patient don't want to go for open surgeries, and we can offer ablative techniques. This cryoablation and radiofrequency ablation and thermal ablation. These three modalities has been routinely performed in UK with patient which, although these radiofrequency and thermal ablation carries highest rate of recurrence. Microwave ablation techniques and laser ablation, high frequency, high intensity focus ultrasound ablation and irreversible electroporation. These are experimental techniques, somewhere performed, and they should be written in journals or in articles. So, recommendation: offer surgery to achieve cure in localized renal tumor. Offer partial nephrectomy to patient with T1 tumor. Do not perform ipsilateral adrenalectomy if there is no clinical evidence of invasion to the adrenal gland. Offer an extended lymph node dissection to patient with adverse clinical features including large diameter of the primary tumor. Offer embolization to a patient unfit for surgery presenting with massive hematuria or flank pain. Again, carries a weak recommendation. This slide is very important. Do not perform minimally invasive radical nephrectomy in patient with T1 tumor for whom a partial nephrectomy is feasible by any approach, including open. So this carries strong rating according to 23 EUA. So patient can be offered open surgery, rather go for a minimal invasive surgery in case of partial nephrectomy. So indication, what are the indications of partial nephrectomy? Any T1 0 to 7 centimeter, even with normal functioning contralateral kidney. A tumor in solitary kidney, bilateral kidney tumors. If contralateral kidney is threatened, affected by stone, CKD or hypertension. In these conditions, we go for DMSA scan for renal split renal function. Like we look for the viability of kidney, either is going to nephron sparing surgery, the remnant kidney will go for good functioning or not. So for this differentiation, we would advise patient DMSA scan. Williams tumor. So contraindications are nodal MET positive, clinically IVC thrombus and renal vein thrombus positive. Pelvic cell system involvement is a straight away contraindication for NSS. Then renal hilar involvement. If hilum is involved, then there is no need of nephron sparing surgery. So approaches, gold standard is open, laparoscopic hand-assisted laparoscopic partial nephrectomy and robotic. These three are the techniques. Associated procedures already told in guideline. Ipsilateral adrenalectomy is subjective. Location was not predictive, but size was. So if size is like tumor in the upper pole and carries huge size, then we go for CT, RTD or venography, and involvement of the adrenal is very important. Lymph node dissection still controversial in T1 disease. Embolization, no benefit other than frank hematuria and fragile patients. So anesthesia is GA, deploy retrograde catheter plus Foley. Retrograde catheter is important in case of while doing surgery. If you open the pelvic system, then we need to inject the diaphragm just to confirm the repair as well. So approach is extra, position is lateral flank position, approach is extrapleural, extraperitoneal flank, incision depends mostly 11 rib tip incision, procedure is open the retroperitoneal space, loop the ureter, deploy self-retaining retractor, dissect the hilum, loop the artery and vein, start mannitol. We'll discuss why mannitol is important in this case. There are 5 techniques of nephron sparing surgery: enucleation, polar segmental nephrectomy, wedge resection, transverse resection, extracorporeal partial nephrectomy with renal autotransplantation. Never seen this before, although these 3 were seen in my training. So simple enucleation, it's simply enucleate the tumors surrounded by a distant pseudocapsule of fibrous tissue, circumferential incision of the renal parenchyma around the tumor at any location, often with no vascular occlusion. Higher risk of leaving residual malignant cells in the kidney. Enucleation is indicated only in VHL disease like in Wilms tumor and multiple low-stage encapsulated tumors involving both kidneys. Then polar nephrectomies. This one is the tumor part. You get the margins of recommended margin is 1 mm. So normal parenchyma is also transected in polar nephrectomies. This tumor part is removed. This is a repair which is done by the chromium 40 sutures. We use micro 40 over here. So this is the repair. This is called polar nephrectomy. Then wedge resection indicated in peripheral tumors on the surface of the kidney, particularly one that are larger or not conformed to either pole. Like it involves the upper and mid pole. Most the part is exophatic. So this technique is associated with heavier bleeding. It should be done with temporary renal artery occlusion and surface hypothermia. This line is very important. In wedge resection, the tumor is removed with margin of normal renal parenchyma. This is the graphic representation of wedge resection. This one is the tumor part involving the upper and mid pole and somehow little bit of lower pole as well. With the help of scalpel, you give an incision. The tumor bearing part is removed. Often a surgical or like we use conjustone. After repair, it has been placed over here and the defect has been closed. This resection has been performed in gilgit, which show later on. Transverse resection. This is done for to remove large tumor that involve the upper and lower portion of the kidney. Major branches of the renal artery and veins supplying to the tumor-bearing portion of the kidneys are identified in the renal hilum, ligated and divided. As you can see, this one is the huge tumor involving the upper and mid of the mid pole, half of the mid pole. This one is the line of the dissection. You can see the renal branches of the renal vein and renal artery has been transected and divided. Tumor part is removed and here is the repair area. You can see the closure of the kidney and the remnant of the kidney. So intraoperative renal ischemia. It's a very important topic, carries very importance in nephron sparing surgery. Temporary occlusion of renal artery is necessary in nephron sparing surgery, especially for larger tumors, those fit for according to the renal scoring system for nephron sparing surgery. So temporary artery occlusion is not only diminish intraoperative renal bleeding but also improve access to the intrarenal structures by causing the kidney to contract and by reducing renal tissue turgor. So this is the benefit of renal artery occlusion. Renal artery occlusion causes reduction in medullary blood flow with reduction in oxygen delivery to the tubular structures. This will lead to cellular injury due to imbalance between oxygen delivery and demand. So endothelial injury is caused by due to leukocyte activation, release of vasoactive substances, swelling and injury of the endothelial cells. So tolerance, renal tolerance to warm ischemia. The extent of renal damage after normothermic arterial occlusion depends on the duration of ischemic insult. The warm ischemia time is 30 minutes. It's not more than 30 minutes. If you go beyond 30 minutes, the recovery of renal function is either incomplete or absent. It affects mostly the proximal tubule, whereas the glomeruli and both blood vessels are generally spared. The solitary kidney is more resistant to ischemic damage than the paired one. Don't know the reason why. Presence of an extensive collateral vascular supply increases the tolerance to the temporary artery occlusion. The method employed to achieve vascular control of the kidney is the important determinant of the renal ischemic damage. The impairment is least when the renal artery alone is continuously occluded. Continuous occlusion of renal artery and vein for an equivalent time interval is more damaging because it prevents retrograde perfusion of the kidney through the renal vein and may also produce venous congestion of the kidney. Intermittent clamping of the renal artery is also more damaging than continuous arterial occlusion because of the release and trapping of vasoconstrictor agents within the kidney. Manual renal compression to control intraoperative hemorrhage is more deleterious than simple arterial occlusion. So how to prevent the renal ischemia while doing NSS? General measures is preoperative and intraoperative hydration, prevention of hypotension, avoidance of unnecessary manipulation or traction on the renal artery, intraoperative administration of the mannitol. These factors ensure optimal perfusion with an absence of cortical vasospasm at the time of arterial occlusion, which allows uniform restoration of blood flow throughout the kidney when the renal artery is unjammed. Mannitol is most effective when it is given 5 to 15 minutes before arterial occlusion, 1 mg per kg. It increases renal plasma flow, number 1, decreases intrarenal vascular resistance, minimizes intracellular edema, and promotes the osmotic diuresis when renal circulation is restored. So this is very important step while doing NSS. Protective measures, local hypothermia is the most effective and commonly employed method. Lowering renal temperature reduces energy-dependent metabolic activity of the cortical cells with a resultant decrease in both the consumption of oxygen and breakdown of adenosine triphosphate. The optimum temperature of hypothermic in situ renal preservation is 15 degrees centigrade. It's very difficult to achieve. It's very difficult to achieve uniform cooling to this level because the temperature of adjacent tissue and need to expose a portion of the kidney to perform the operation. So the temperature of 20 to 25 is easier to maintain with renal preservation effect. This level of hypothermia provides complete renal protection from renal occlusion of up to 3 hours. There are two types: external surface cooling or perfusion of kidney with a cold solution instilled into the renal artery. Again, it's invasive and not routinely doing nowadays. The two methods are equally effective. Surface cooling of kidney is simpler and widely used method. Surrounding the kidney with cold slush, applying an external cooling device to the kidney. So ice slush cooling, here you can see this is the plastic bag. Once you dissect the whole kidney, only spare pararenal gerota and perirenal fat over the tumor. All over the kidney has been dissected along with the renal hilum and renal artery. Once you have control of the artery, then you pack the kidney with the ice slush. So this can help the procedure up to 2 to 4 hours. So warm ischemia is not more than 30 minutes. These two are the golden rule of today's presentation. So a case performed in RHQ. A 45-year-old young lady came to OPD with complaints of right lumbar pain for past 2 weeks. Pain was dull in nature, non-radiating and non-aggravating with movement. Associated signs and symptoms like hematuria, lower urinary tract symptoms, contralateral pain, fever, traumas, previous surgery, coma, vomiting, vertigo, dizziness, bone pain, hemoptysis were unremarkable. Systemic review was also unremarkable. General physical examination was normal, including abdominal examination were not massified. Upon detailed investigation, as previously told in my presentation, it turned out to be a right renal mass, localized clinically T1D. Patient offered detailed counseling regarding the nature of the surgery. Obviously a difficult part. The patient is still fighting with me why you have left my kidney behind, although I had a tumor. Is continuously followed with me. It has been 3 months right now. So patient was subjected for nephron sparing surgery. Here are the CT scans, a coronal view which shows in this picture, if you appreciate, this one is the normal kidney. Here is the tumor part which is abutting the liver as well with the intact interface, and it's partially, it seems to be infrarenal. It's more than 30 to 40% exophytic and 40% is endophytic. So this is the coronal view of the patient which underwent nephron sparing surgery. Here is the line of incision. Midline subcostal incision was given, although recommended was flank. So I am comfortable with this incision. This one is the tumor part which was removed. Here is the tumor part. This one is the normal parenchyma attached with the tumor, and this was the wedge resection performed. We are playing you guess it is. Our anesthetist, Dr. Zia, everyone knows. These are our chambers of operation theatre. Dr. Umer, my assistant. So and you can see the upper pole and the mid pole. This one is the line of repair. Is the anterior and this one is the posterior. It was a huge tumor, 6 to 7 centimeter in greater dimension. Subcostal approach. The kidney has been, the clamp has been removed. Routine surgery. Dr. Rehman is total guidance along with us. So this was the surgery performed in our setup. So the histopath, it turned out to be a clear cell carcinoma, which was limited to kidney. Everything was absent. The renal parenchyma resection margin was 0.2 centimeter away. Here you can see tumor free. Capsule surface 0.2 centimeter, tumor free, and it was PT1B. In histopathology, the histological type was clear cell carcinoma. Histological grade according to WHO was grade 2. Tumor size was 4 into 3 into 3 centimeter, that is T1B. So once surgery has been performed, and the difficult part is the oncological outcomes, and little bit talk about oncological outcomes. Positive surgical margin is encountered in about 2 to 8% of all NSS. Surgical margins with different surgical approaches are inconclusive still. Intraoperative frozen section has no influence on the risk of definitive positive surgical margins. The potential negative impact of positive margin status on oncological outcome is still controversial. This one study which quoted this recurrence, local tumor bed recurrence is 16% in patient with positive surgical margins compared with 3% in those with negative surgical margins. Positive surgical margins, more intense follow-up is recommended. Protection from recurrence is not ensured by negative surgical margins. So in follow-up, same as RCC, surveillance after treatment of RCC nephron sparing surgeries allow the urologist to monitor and identify post-op complications, renal functions, new onset diabetes and hypertension, local tumor bed recurrence, mets and recurrence in the contralateral kidney. So this one is the follow-up plan. Ultrasound 6 months, at 1 year CT, a 2 year ultrasound, at 3 year CT, for greater than 3 years CT once every 2 years. Counsel about the recurrence risk, that is 10%. In patient with intermediate or high, we had to do CT first in 6 months, then yearly, and for 3 years, then CT once every 2 years. Intensify follow-up in patient after nephron sparing surgery for tumor greater than 7 cm or patient with a positive surgical margins. You can see strength of rating is weak. Thank you so much for listening.